Chapter 3. All Natural Breast Reconstruction. Simply stated, all natural breast reconstruction uses a woman's own tissue in order to optimize the size, shape, and appearance of her chest after breast cancer treatment. It is a safe, effective, and predictable way of reconstructing a breast without using any foreign material, such as silicone implants. Another way of thinking about it is that it is a transplant from one part of a woman's body to another. This tissue can be collected from many different areas, including the lower abdomen, the back and flank, the thighs, and the buttocks. We'll talk more about the details of each of the most common forms of this procedure a little bit later on. The history of all natural breast reconstruction goes back over 100 years. The very first documented attempt at using a woman's own tissue to recreate a breast after mastectomy was in 1895, when a surgeon tried to move a very large lipoma, a very common benign fatty tumor, from a woman's back to her chest. Unfortunately, this did not succeed, but it was a first step in the breast reconstruction revolution. The first documented successful form of breast reconstruction involved movement of skin, fat, and muscle from the back to the chest. This latissimus muscle flap is a tried and true technique that is still occasionally used to this day. Buttock tissue has been used since the late 1970s, first as the S-gap or I-gap flaps, superior gluteal artery perforator flap and inferior gluteal artery perforator flap, respectively. Very recently, the lumbar artery perforator flap has been described, which is a delicate microsurgical procedure that uses the same tissue as the S-gap and I-gap, but has fewer complications. Thigh tissue was first used via the gracilis muscle-based flaps in 1992, taking the form of tug or dug flaps, transverse upper gracilis or diagonal upper gracilis flaps. More recently, the PAP flap, profunda artery perforator flap, has been introduced as a muscle-sparing thigh flap, as has the LTP flap, lateral thigh perforator flap. Most importantly, the skin and fat from the abdomen was first used in the early 1980s, when Dr. Carl Hartranft and his colleagues in the Atlanta area developed the TRAM flap, transverse rectus abdominis musculocutaneous flap. This involved moving one of the six-pack muscles, rectus abdominis muscles, with the overlying skin and fat. This was a huge step forward because it utilized tissue that was usually plentiful, but not particularly appreciated in that location. Hence why people sometimes seek tummy tuck procedures in order to get a cosmetic enhancement of the abdomen. So the TRAM flap took tissue away from an area in which it was plentiful but not wanted, lower abdomen, and moved it to an area where soft, fatty tissue was wanted but no longer present, the chest, after a woman has had a mastectomy. A win-win. For as great as this was, it was not without its drawbacks. Most of all, repurposing the rectus abdominis muscle was tolerable, but did lead to some functional consequences. So over the next 20 years, surgeons realized that they could perform first a partial muscle-sparing procedure, muscle-sparing TRAM, then a total muscle-sparing flap procedure, DIEP, or deep inferior epigastric perforator flap. Another variation of the total muscle-sparing flap procedure from the lower abdominal wall is the SIEA flap, superficial inferior epigastric artery flap, but that has been used less commonly in recent years because of a higher likelihood of problems with the blood vessels. Finally, there has always been interest in the potential of fat grafting, where fatty tissue is collected via liposuction and then injected into the breast. This technique is still in its relative infancy and has significant limitations that have so far kept it from becoming an established technique for breast reconstruction. But as more research and experimentation is done, fat grafting injections will likely become a viable technique in the years to come. So, who is all natural breast reconstruction good for? The easy answer is almost anyone. This is particularly true for women who are undergoing one-sided reconstruction, and therefore have a native breast that they are trying to match for symmetry. Those who have undergone or will undergo radiation, those who have very low or very high body weight, those who have already undergone implant-based reconstruction and have developed an animation deformity, where the breast skin scars to the chest muscle and leads to rippling, particularly with arm motion, those who have developed capsular contracture, and those who have a significant volume and symmetry deficiency after having previously undergone a lumpectomy and radiation. The benefits of all natural breast reconstruction are first and foremost that the tissue is your own. It is alive. It is soft, natural, and warm, which is in distinct contrast to foreign bodies such as breast implants, which are distinctly not alive and are often firm and cool to the touch. Furthermore, when it is performed for unilateral reconstruction, the symmetry between the fatty tissue of all natural breast reconstruction and native breast tissue is so much greater than it is between silicone and native breast tissue. It also allows you to nearly completely avoid the complications that can occur when a woman has silicone or saline breast implants for reconstruction. These potential complications include infection, rupture, capsular contracture, and even some alternative forms of cancer, such as anaplastic large cell lymphoma, ALCL, and squamous cell carcinoma, SCC. Additionally, all natural breast reconstruction gives the opportunity to replace skin that is either present but damaged, especially after radiation, or outright absent because of prior skin loss or contraction. Finally, because the tissue for all natural breast reconstruction needs to come from somewhere on each woman's body, if it is done smartly and intentionally, it can create benefits at the donor site, such as tighter, tauter skin on the abdomen or thighs. So we have discussed who all natural breast reconstruction is good for, but it is not necessarily right for everyone. While the amount of tissue available for use on a woman's lower abdomen is usually well matched for the size of a breast that is in need of reconstruction, there are a small number of women for whom the amount of abdominal wall tissue is not enough for the reconstructive needs, especially if both breasts are to be reconstructed. But even in this case, there are additional options, which include using 2 flaps for one breast, or using a hybrid approach where 1 flap and 1 implant are used at the same time. But that woman might be one who is better suited for implant-only breast reconstruction. Additionally, women who have blood clotting disorders, often indicated by episodes in the past of blood clots in the deep veins of the legs, or multiple miscarriages, because blood clots can be one reason why that unfortunate situation occurs, are at higher risk of having blood clots occur in the fresh connection between blood vessels that allows for the immediate restoration of blood flow in the transplanted tissue. These women are not necessarily prohibited from undergoing all-natural breast reconstruction, but the likelihood of success decreases slightly, and this must be carefully considered. And finally, women who have significant medical issues that make it unsafe to undergo general anesthesia, such as lung or heart issues, should carefully consider the risks and with their doctors jointly determine whether they outweigh the benefits of an all-natural breast reconstruction procedure. Safety should always be considered above anything else, but fortunately, these types of procedures have become exceedingly safe. Now that we've covered what all-natural breast reconstruction is and who it is good for, you're probably wondering how it works. We're going to cover that and more in the next chapter.